The next topic is pancreatic cancer. So a completely different sort of ball of wax, and in a lot of ways, from the diseases that we talked about earlier. As you all know, pancreatic cancer is a deadly disease. It is the fourth leading cause of cancer death in the United States. The incidence rate almost equals the death rate. So as we all know, people get pancreatic cancer and they die of it very quickly. The overall 5-year survival is 6%. There's been no change in the survival in the past 40 years. And there are no options right now that are available for population-based screening. So that's not what we're talking about today, but clearly it's a terrible disease to have, and people are petrified of it. So when we think about hereditary susceptibility, very similar pie chart. Oh, wrong way. Okay, it's not working. To what we saw before, 90% of pancreatic cancer is not hereditary. Again, you have people with this sort of moderate level of pancreatic cancer family history, and then a small subset of people who have, thank you, much better, sort of inherited very high risk of pancreatic cancer. So let me show you a typical family. So the celebrity that's associated with hereditary pancreatic cancer is Jimmy Carter. Jimmy Carter's family has actually, the ex-president has 6 or 7 cases of pancreatic cancer in it, and no gene identified, and he clearly doesn't have it, but lots of his family members have died. This is a 50-year-old with pancreatic cancer. There's a pancreas cancer here. There's another one here. Can't see it. And there's another one right here. So 3 or 4 cases of pancreatic cancer. You've got some breast cancer. You've got some colon cancer. But clearly there's an excess of pancreatic cancer in this family. And let's think about, should we be screening this family for pancreatic cancer in any way that's different from what you would do for your average patient? So the context of the discussion is twofold. We're going to talk about screening for hereditary pancreatic cancer syndromes. So in the same way that we did for the other diseases earlier this morning, when do you need to be thinking about a familial predisposition to pancreatic cancer in terms of a genetic disease? The second thing we're going to talk about is screening for pancreatic cancer itself. So once you identify some of these high-risk families, does screening ever make sense? And if you're thinking about screening, what screening should you be thinking about, and what's effective? So some definitions first. Familial pancreatic cancer is defined with as 2 or more relatives with pancreatic cancer and no known associated syndrome. So 2 relatives, gets you some elevated risk. The really important families are these. So it's high-risk familial pancreatic cancer. There are people with 3 or more cases of pancreatic cancer in them. And if one of them is a first-degree relative of your patient, then you really got somebody who's at very high risk. And that's really the sort of patient population I want you to be thinking about, because we're going to be talking about lots of things that seem sort of, out of the ordinary and very aggressive in these patients. So we're not talking about the average person with 1 family member with pancreatic cancer. We're talking about 3 or more cases of pancreatic cancer. And then what kinds of risks are we talking about? So this is why we're concerned. 40% lifetime risk of pancreatic cancer if you have 3 relatives in your family. So again, when we talked about how deadly it is, this is not a familial disease that you want to have. The risk is much lower if you've got 2 first-degree relatives, and this is about the general population risk in the US. Now, the first thing is that there are multiple known syndromes that are associated with an elevated risk of pancreatic cancer, and they're listed here. So we talked about breast cancer and colon cancer, there being no overlap. It is clear that people with BRCA mutations have an elevated risk of pancreas cancer. This is especially true for BRCA2 mutation carriers, and whether there are certain families that pancreatic cancer is sort of, concentrated in is not clear. I think we need a lot more data. And what's interesting is that in the BRCA families, the women are the ones that come to attention because of the breast ovarian cancer. The males don't get cancer generally because they're men and the cancers that they're at risk for don't occur in them. But what's emerging is that these mutation carriers often present with pancreatic cancer that are the obligate carriers in the family. So if you see breast and pancreatic cancer in the same family, think about a hereditary predisposition to disease. Familial atypical multiple mole melanoma is called FAM, associated with P16. We'll talk about it just briefly. Lynch syndrome, we spoke about. Clearly, there's an increased risk of pancreatic cancer in some of these families. Peutz-Jeghers syndrome, dramatically elevated risk of pancreas cancer. And I'm not going to talk about this, but hereditary pancreatitis is a very rare disease associated with inherited germline mutations, also 40 to 50% lifetime risk of pancreatic cancer. So that patient population probably needs to get surveyed. More recently described associations include PALB2 and ATM. So again, let's talk about sort of what risks are we talking about. Peutz-Jeghers syndrome, 35 to 40% lifetime risk of pancreatic cancer. Really high. So we worry about the polyps. It's really the pancreatic cancer that's more likely to kill them than anything else. This FAM syndrome, 17% lifetime risk. In the BRCA families, the lifetime risk is not that elevated, but clearly, at least double that of the general population. And this is the data I showed you earlier, a 4% lifetime risk of developing cancer. So Peutz-Jeghers, I don't think we need to go into this. We talked about this earlier. Multiple extra GI tumors and pancreatic cancer risk we've talked about. The FAM syndrome is P16, and really what you're looking for is family members with lots of melanomas or lots of dysplastic nevi. And if you see that concurrently with pancreatic cancer, think about P16 and an elevated risk of pancreatic cancer. Lynch skip. And then HBOC, we've talked about. The interesting thing in this is that some of these families dramatically don't look like breast ovarian cancer families. So sometimes if you see 3 cases of pancreatic cancer, like the one I showed you, there may be only 1 case of breast cancer. And what we do, because the risk is so elevated, that if we see a family who comes in with multiple cases of pancreatic cancer, the first genetic test we do is test for BRCA1 and 2 clinically. Almost every patient gets BRCA1 and 2 testing because there's probably a 10% risk of having a BRCA mutation if you've got 3 cases of pancreatic cancer. And then there's been a large-scale effort for years now around the country, around the US, to look for the gene for pancreatic cancer in all these families that clearly have elevated risk but don't have a defined syndrome. So the bottom line is that there are subsets of patients and families that have an increased predisposition to develop pancreas cancer, and there's likely going to be an increasing number of potential genetic etiologies that explain the risk in these families. So what do we need to figure out what to do to help these families. And in this, because the interest has been so sort of marked, I think that the field that's looking at screening has moved along concurrently with the genetic field. And it has focused really on all these unaffected members in that family. What should they be doing to affect their pancreatic risk, and is there anything that can be done to help them? So what are the management options that are being considered or that are being evaluated? So it's really radiologic and endoscopic. Screening with endoscopic ultrasound is high on the list. Imaging, which is, and we're going to talk about the data for both of these, CT as well as MRI and MRCP. The hallmark of screening is aggressive evaluation and management of precancerous lesions. And really the big feature that we're looking for is the IPMN in the pancreas when you do these screening tests. And people always talk about prophylactic pancreatectomy. It's really rarely done. So we're not talking about taking out people's pancreases because, it's really a highly morbid operation. You can live without your breast, you can live without your colon. Living without your pancreas is a much more complicated issue. And in fact, some of these patients who've gone on to prophylactic pancreatectomy in the early studies did not do well. There was a high mortality rate. So it's really something that we rarely do. I don't think I've sent anybody to a total prophylactic pancreatectomy despite very high risk. Now, what are the precursor lesions? So we talked about IPMN. You're used to seeing these in your general population. These are the visible, they're mucin producing. It's an epithelial neoplasm. They can be main pancreatic duct or side branch ducts. And there are certain features that have been defined that increase the rate of malignancy. So dilated main pancreatic duct is a high-risk feature. If you see mural nodules, it's a high-risk feature. Size is a big predictive factor, so a size of greater than 2 to 3 centimeters is important. And cyst fluid has been looked at, so looking and aspirating the cyst for CEA, CA19-9, and serologies are all being used in clinical practice with sort of moderate success to define risk in the sporadic population. In the hereditary population, what is interesting is that IPMNs are felt to be sort of a field defect, meaning that a lot of these hereditary families have lots of IPMNs. It's not the IPMNs that may be getting malignant or becoming malignant, but if you have a lot of them, or if you have a big one, or if you have one that's increasing in size, that may be a marker for something that's going on in your pancreatic tissue underneath. And what's going on? So the progression of pancreatic neoplasia has also been quite well worked out. It's not really as well sort of understood or appreciated as a colon, but it's a very sort of similar process, that there's a multi-step progression of neoplasia in the pancreatic tissue. This is this is microscopic. You need to look at the pancreatic tissue to define it. And the sort of classic lesion is a Panin lesion. You have different degrees of Panin, so Panin grade 1, grade 2, grade 3. And what has also become clear is that there's a higher rate of Panin lesions in people with familial pancreatic cancer. So for these people who have undergone resections, you have multiple individuals who have multiple Panin lesions. They are more likely also to be high grade. They probably have a different mutational spectrum, and they seem to be associated with features in the EUS for chronic pancreatitis. So we have sort of, an orderly progression as well in the pancreas as we do in the colon. And Mimi Canto, who's really done, a lot of the work in this from Hopkins, the slide is from her, and she sort of thinks of multifocal Panin lesions or IPMNs as the colonic polyposis, of the pancreas. That in the same way that we think of multiple polyps as being a hallmark feature, if you see somebody with multiple Panin lesions or multiple IPMNs, think again of some genetic predisposition to pancreatic cancer. So imaging, CT scan, has been looked at or thought about for quite some time. It's relatively low cost when we talk about the other imaging modalities. It's widely available. You can have a standard CT-guided protocol, and it can detect large lesions. The disadvantages are that multiple studies have shown now that there's limited sensitivity when you compare it to EUS and MRI, so it's really fallen out of favor. You obviously have the radiation exposure, so I think very few of us are using CTs as a screening tool in these patients. How about MRI, MRCP? There's a high accuracy, there's no radiation. It's not operator dependent for the most part, but of course it's a very costly test. It can't detect these microscopic lesions, and there's some patient-related factors that make it problematic for some patients. But really, MRI is, an MRCP, dedicated MRI, is one of the sort of top tests under consideration. And then EUS, from our sort of specialty, is the other one that's being looked at. The advantages are that there's no exposure to radiation. It provides high-resolution images. There's a high accuracy, probably higher than MRI for cystic lesions. And you can look at the parenchyma and give some assessment of that. The disadvantages, as you know, is, again, high cost, not widely available, and there's a very high observer variability, and you really need to be trained in this sort of field. In particular, what are the lesions that you need to pay attention to when you sort of pull the trigger that somebody's high risk? And then, of course, you have the risk associated with sedation and endoscopy. So there has been a lot of single center studies that have looked at the efficacy or the potential role of these studies, these tests in these families. And just last year, there was a multi-center study that many of us were involved in that looked at detection of pancreatic lesions with all three of these modalities in high-risk individuals. And I'll just show you the data for that. So this multi-center study enrolled 216 patients who had familial pancreatic cancer. So the vast majority of them, did not have a defined mutation. They just had those multiple cases of pancreas cancer. 21 of them had a known familial syndrome, and every patient had all 3 tests. So they all underwent CT, MRI, MRCP, and EUS. CT scanning had a much lower sensitivity, as I said, compared to MRCP and EUS. And these were the results. So 42% of patients had a focal pancreatic lesion. So just sort of sit with that for a second. You're going to screen these high-risk patients. You're going to do something. 40% of them are going to come back with an abnormal test. So that, you can see, creates a lot of problems. Most of them were not high risk. So only 5 of these lesions had dilation of a main pancreatic duct. Some of them had a solid component, but most of them were sort of small IPMN lesions. As you increased in age, you had a higher risk of having these IPMN lesions. Only 12 patients needed some sort of invasive procedure beyond the EUS or MRI. They underwent FNA. And out of all these patients, 5 patients underwent pancreatectomy. And all of these, the vast majority of them were segmental resections. So I'm not going to go through the details of this, but many of these patients had segmental resections, and they had high-grade Pennin lesions. So they were not pancreatic cancers that were detected, but they had high-grade dysplasia. And one of these patients is one of our patients, and clearly this was a save from pancreatic cancer in a family, in a patient who had 4 family members who had died of pancreatic cancer. So, we need to do sort of a lot of screening to help a few patients, and it's not clear exactly whether this makes sense outside a clinical trial. So a couple of years ago, there was an international summit, again, sort of encompassed by the people at Hopkins, and these were the questions that were debated. Who should be considered high risk? What screening options should be offered? How often should they be done? When should screening begin? What should be the trigger for intervening surgically? And then what surgical interventions should be done? And this paper, you look for it in Gut this year, was just published. And I'll just go through a couple of sort of, conclusions from this. When do we start screening? Pancreatic cancer, doesn't occur very early, even in these families. So I talked about, younger than age 50 in colon cancer. That's not true in pancreas cancer. These families, these people get cancers in 65, 70-year-olds. They just get too much of it. So the recommendation is to start at age 50 or 10 years younger than the earliest age of diagnosis. The exception is Putz-Jaeger's. So it's really, in these sort of high-risk centers, the recommendation is Putz-Jaeger's patients should start screening between the ages of 30 to 35. You should do it every 1 to 2 years if normal, baseline. And what we do is we alternate EUS and endoscopic ultrasound with MRI once a year. Now, what about surgical options? As we talked about, you can do Whipple procedures, you can do distal pancreatectomies or total pancreatectomies. Really, the goal is to remove the high-risk lesion, and that's about it. So if you keep on actually resecting, the surgeons were very interesting. They said if you go into the OR and do frozen sections in the operating room and keep on resecting, you're going to find more and more Pennin lesions, and you'll end up having to take out the whole pancreas if you rely on that. So really, you have to have a focused resection and tell the patient that you may not have gotten all the high-risk lesions that is out there. So as we finish with this, so reasons to screen high-risk individuals, there are surgical options, and I think what we don't know right now is should these sort of the criteria for intervening surgically be different in these hereditary families. Should we have a lower trigger for surgery, less than 2 centimeters? What we really do is look for the change in size primarily. So we follow patients. If you see an IPMN and it seems to be getting bigger in size, that's when we put our heads together and strongly consider sending the patient to surgery. Reasons not to screen. There are lots of reasons not to screen, and there are no data on the survival benefit from screening and treatment of asymptomatic high-risk individuals. The sensitivity is low, so I'm convinced that some of these tests are just not sensitive enough. We've had several patients who are getting annual screening who have developed advanced pancreatic cancer, while they're getting screened. And I think that's the limitations of the technology. So I think we have to think probably more molecularly in this disease than radiologically. So the tests are probably just not good enough. The big issue is false positives. So these people, you're not talking about taking out, a polyp endoscopically. You're talking about sending them to surgery and getting a pancreatic resection. And so the false positive issue is a huge issue. This is not, and the quality of life in patients undergoing screening is really something to be considered. So these patients are very anxious, and as you can imagine, you start with a baseline anxiety, and you tell them that they've got something very abnormal. You're talking about surgical resection. I think that's the biggest risk in managing these patients. So the next step in this is an international consortium that's being convened right now to look long-term at long-term follow-up of these high-risk patients. So just the final cautionary comment, this is an entirely different scenario than colon cancer screening and surveillance. So when I start, talking to a patient who's at high risk, the discussion takes a long time. And what we say is, that we don't know what we're doing. We don't know if this works. We may be sending you to surgery for something that's not going to help you. So you have to think very, very carefully before embarking on this road. And that there's a very high likelihood that I'm going to call you with an abnormal test that will need to be followed over a long period of time. So we do it very responsibly, we do it carefully, but we do think that in certain subsets of families, this has a role. So who does it have a role in? More than 2 relatives. So 3 relatives on the same side of the family with pancreatic cancer. Any of these mutation carriers who have a pancreatic cancer in their family, and then all patients with Peutz-Jeghers syndrome. How do we screen? We talked about annual screening, alternating MRCP and EUS, and then when we also spoke about age greater than 50 or 10 years earlier than the earliest diagnosis in the family, and the exception here is Peutz-Jeghers, where you start at the age of 35. So just to finalize, there are known inherited cancer syndromes that predispose to pancreatic cancer. However, the genetic basis for familial pancreatic cancer is largely still undefined. With EUS, MRI, and MRCP, we can identify precursor lesions, and these tests have a significant yield in appropriately selected high-risk individuals. The optimal frequency and approach is yet to be defined. And we don't know if in the long term this is going to impact mortality, but I think it's really an area of high interest, and we're going to see a lot more, again, in the next few years, hopefully, that helps these patients. Thank you.